it's appropriate, that it's cost-effective, and if it's patient-centered, it would be what would the patient tell us they would want. Another way is what's most important to them. You know, when I ask patients who are cognitive and can talk to me, or the people who love them, when I say, what's most important to them today? That causes pause for thought. And I might say, is it moving the PICC line from the left arm to the right? Is it leaving the nursing center to go to the emergency room? Is that the most important thing today? Or is there something that's more important to that patient today? And that will cause thoughtfulness on their part. The patient-centered quality readmission point. What's most important to them today? So readmissions in Florida, you know, it just doesn't feel good to be at the bottom. So where are we today? Amy, where are we?
52nd.
So we're 52, we've moved up. There are 50 states, and we're 52, but we used to be 53. So that means we're got ahead of Guam.
We're ahead of D.C.
Oh, we're ahead of D.C. But we're behind Guam. Not that Guam is the standard, but not many people think of that. So we're probably behind America, Samoa, the U.S. Virgin Islands, but not D.C.
We actually dropped Guam off the scale because it was just so small. So now where we are.
So Guam is no longer measured. So I think that may be important. But it doesn't feel good to be at the bottom, does it? No. So, and excuses abound. Why is Florida near the bottom? Near the bottom. And you will hear excuses. I'm doing a good job, so the hospitalist might say, so the discharge planner might say, so the intake admission nurse at long-term care, so the physician writing the prescriptions at the hospital to get to long-term care, so the non-emergency medical transportation that gets them there with their envelope and their packet with the prescriptions in them says, we're doing a good job, we always deliver everything on time, and they're an important component. I'm doing a good job, it's those other people that are. So that's the silo excuse. Our patients are sicker. Doctors love to say that. I have a neurosurgeon in Palm Beach right now, a trauma neurosurgeon, who says he's incredible. You don't have to ask other people, you can just check with me. And he says his patients are sicker, and that's why his post-surgical death rate is different than others, because his patients are sicker. You've heard the our patients are sicker story forever. Or multiculturalism. You know, here in Florida, I think there are 38 commonly spoken languages in Broward County. It's incredible. It's incredible. And it is because of multiculturalism that we're not able to communicate the issues to our patients and families, and therefore, that's why our readmission rate is higher. And limited resources. Well, you know, we're in Gadsden County. Now, actually, I think I understand that in Gadsden County, they may have the lowest readmission rate in Florida. They don't have a hospital in Gadsden. Yeah. And so, we have limited resources. You know, they had to go to the hospital. We can only do so much where we are. You know that excuse? We've done everything we can. We have limited resources. And the best excuse of all, which is almost always lame, is we are unique. There's really no other place like us, and that's why. So let me just say, from my experience and from education, if any healthcare anywhere uses "we are unique" as an excuse, they aren't. But you can't talk about it anymore because they're different than everybody else. So in healthcare, almost nobody is unique. Almost nobody is unique. That's just a silly excuse. But that's what we hear, I think. And this is for discussion today. We hope at the end we get some lively discussion, not just about the issues and the challenges, but about the next steps in the implementation. And who among us, personally and in our agency and organization, can be champions of helping make whatever changes we talk about. So the value proposition is quality and cost. So, cost. The sickest, you've heard these numbers forever, the sickest 5% of the Medicare patients cost 50% of the Medicare dollars. So where do you think these 5% of the patients are? Well, they're in the ambulance, they're going to the ER, up to the ICU, back to the nursing facility. You've also heard that for any one Medicare patient, 50% of their lifelong spending occurs in the last 6 weeks. Half of the Medicare dollars was not spent for just wellness. It was spent in the last 6 weeks of their life. Those statistics have been around for 5-6 years. I'm sure the numbers have changed a bit, but they're still impactful. And it costs a whole lot more to die in Miami than in Portland, Oregon. There was a study several years ago, what was it, $67,000 in the last 6 weeks of life in Miami and $14,000 in the last 6 weeks of life in Portland. So, you have lots of reasons for that, I think. I think in Miami, everybody's cousin is a specialist and they want the whole family on the case. So, and in Portland, nobody's related to anybody, I think. But it's the culture. It is the culture. Even where I am in West Palm Beach, down to Hollywood and past, I can feel a healthcare culture change as I go from hospital to hospital just in that distance. And hospital admissions are very expensive. That's where the cost is. That's where the cost is in med-surg and in ICU. So, quality, the value proposition of quality. What are the clinical outcomes that we're looking for to avoid a readmission? Well, it might be sugar control or wound healing or aspiration is prevented or improved balance, decreased falls. So we'd like to have clinical value so that that patient would not have to go back to the hospital. How about long-term care outcomes? You know, this is really a conflicted, bit of a schizophrenic, because in the Medicare regulations in long-term care, post-acute care, our obligation is to recover, rehabilitate, to help lift them to the highest degree of independence. Yet when someone comes to long-term care, they have declined. They have gone from Karnofsky palliative performance from 80 to 60 to 40 at 40%. So let me do this very quickly. So the Karnofsky, spelled phonetically, but phonetically isn't, and the palliative performance scales both start with 100%. We're all 100%. We're living life large. We're the best looking that we've ever been. We're working. We're thinking. We're funny. And we're making a living. We're planning. We're 100%. If you take a prescription for hypertension, you're still doing all those things, but you may be 90. And if you're taking a prescription for hypertension and for a little arthritis, you might be 80, but you're still living life large. When you drop down to 70%, this is cognitive and physical, then you may need somebody to help you to your doctor's appointment. You probably don't just have one. You may have a couple, a specialist. By the time you're 60%, you may need Meals on Wheels at home or somebody to come by and remind you of the trash day. When you're at 50%, you really need a driver to get you to your doctor's appointments. When you're at 40%, that loving family member who didn't realize that they had been pulled into a full-time caregiver, they're now an exhausted caregiver. And at 40%, these people can no longer stay at home. Even if they're wealthy and live on the island, that full-time caregivers around the clock, they need medication changes, they need assessment, and it's about 40% when most people enter post-acute and long-term care for the long term. And when they get to that 40%, they have cognitive and physical declines that got them there. Those changes don't stop because they get great care, because they get great food, the right diet, the right medications, attention, a doctor's visit, the nurses caring for them, the aides doing skin care. That decline continues. In fact, the average length of time in long-term care, post-acute long-term care, custodial nursing home care, not assisted living or CCRC, and custodial nursing is less than 30 months. So people continue to decline. They can have expected decline. But the regulations say that in long-term care, our job is to recover, rehabilitate, and restore them to the highest level of independence. So there is some conflicted, and I think here documentation and understanding between all of the parties is very important. But we do, in long-term care, our area of focus, want them to have the best care and the best life they can have. So, but for someone with the clinical outcomes in long-term care or in the community, what's most important to that person? What's most important to them? So the theme here is person-centered choice. What's most important to them? Is it to go back to the hospital or not? Or not? And it might be. So readmission causes. So I tried to think that my organization is involved in Lean and Six Sigma. So now you can't say hello without doing a root cause analysis. So readmission causes. This is where you all, as experts, can help me and help us all. Are there other causes? Because if we can understand the causes, and I think we've talked about causes a lot, then can we do something to influence, mitigate, improve, or eliminate that cause? So recurrent medical issue. If somebody has recurrent hypoglycemia, they may go back to the hospital. They may not. We may be able to manage that. So if they have recurrent falls, gravity didn't go away, maybe they will go back to the long-term care. But any recurrent medical issues. How about previous admission gaps? Somebody didn't do something. From the hospital to where they end up, is there some gap? Did they not get the prescriptions? Did they get too many prescriptions? Did the prescriptions get lost between the time they were printed, signed, and got to the admission nurse in our environment? Did somebody not do a wound care plan, and the reason they went to the hospital was an infected wound? They come back with everything else in place except a wound care plan. And they go back with an infected wound. Was there just a gap? We certainly can do better there. If there's a gap, we can close it. In Lean, of course, you know that's gap analysis. So chain of custody is broken. Now, this is when we hear about reports. We've talked about, Amy, on a couple of your work groups that I serve on in Broward and Palm Beach County. We've talked about, well, if a hospital physician could talk to the long-term care physician, that would really close the gaps and reports would be great.